Good morning, ladies and gentlemen. I'd like to warmly welcome you to this special session arranged by Cardiologists of Tomorrow. The entire session, I'd like to let you know, is being live streamed and is an interactive session as well, so that people from all over the world can sit back home and enjoy the session, and will be able also to ask questions via our web moderator. Before just briefly letting Stefan introduce how it works, I've been asked to let you all know that taking photos and films are not allowed except for the press. Stefan Zuili, my web moderator, would you please?
Good morning, everyone. I'm very pleased to be here today as the web moderator. So it's very simple, easy way to send your questions. Feel free to send your question either on the Twitter account, hashtag ESC Live number 2. So if you have a Twitter account, don't hesitate. And I will receive all different questions for all our colleagues all over the world. So I will ask the questions at the end of the presentations. So, dear Chairman.
Yes, I'd like to introduce my co-chairman, Professor Vasco GAMA, and myself, I'm Dr. MADSEN. And could you please introduce the first speaker? Thank you.
Yes, good morning, everybody. I would like to ask Dr. Mette from Finland to speak about hybrid cardiac imaging.
Chairman, ladies and gentlemen, good morning. It's a great pleasure to be here today and be able to talk about the area which I think is very fastly developing. Many of the things, although this is a future sessions, are actually here today. But at the end of the talk, I will give you some near future aspects, what is related to hybrid cardiac imaging. These are my disclosures. Now, if you look about the detection of coronary disease by using different, mainly imaging techniques, we can make such a summary where practically all the modalities have pretty high sensitivity and also pretty high specificity, maybe as an except of a regular exercise ECG. Now, this would then, what does this mean in practice? The problem is that these are patient-based analysis. This tells only how accurately you can detect the patient have disease or not have disease. So that's not very helpful actually for the clinical routine, because you need to decide what to do with the patient. It doesn't help that much to know just, okay, there is disease or not disease. That's not enough. And the other problem in these analyses is that the reference standard here have been invasive angiography based on anatomy only. No functional tests have been used, no FFR in these analyses. So, of course, those tests which have a more anatomical approach, like CT angiography, match better with anatomy. I think the main thing is that currently we are changing the paradigm from diagnosis to guidance of therapy, and recent development of invasive with using also FFR is one of the signs of this paradigm shift. But the same actually can be done today in a non-invasive, by using non-invasive imaging techniques. And there are a lot of data now coming and have already published how to combine different techniques to make the same combination of anatomy and functional consequences of the lesions in a single test. And to be able to combine this information, we can then optimize medical treatment and carefully select the patients to correct therapies, revascularization, PCI, or CABG. Now, we have multiple of different imaging techniques. I can classify them into two categories. One is the anatomical imaging, invasive angiography is an example also. Now, CT angiography is a very well performing test to look about the coronary lesions. Then we have a number of functional tests. Traditionally, stress echo and nuclear SPECT especially have been the workhorses, but recently PET and CMR, and also now invasively FFR has come to the picture. Now, the hybrid imaging actually means that you combine class of anatomical imaging with the functional test, non-invasively or invasively. And if you do that invasively, you will immediately see the big difference in the function versus anatomy. This is the classical graph showing the association between the diameter stenosis in invasive angiography versus the pressure-derived FFR. It's obvious that there is association between the degree of stenosis, but huge scatter. So if you have very tight-looking stenosis, there are a lot of those lesions which are not functionally significant, but also in the intermediate lesions, there are a lot of those which are functionally significant or non-significant. So the anatomy alone never can give you the final solution. You need the combination of anatomy and function, and that's the basis of the hybrid imaging. Now, what we can do today non-invasively, and this is not future, this is the routine, for example, we are doing in daily practice. So there's a combination of CT angiography and the functional imaging test. What we are using is PET-CT because we just happen to have a good facility to deliver that kind of services. But how it goes, that if it's a similar phenomenon, if you look about two patients here, this patient and the other one here, the anatomical findings in the coronaries look pretty similar. You see there's LAD disease and also diagonal 1 disease, here also diseased similarly or comparably. But the functional consequences are very different. Now, how do you do the hybrid imaging? In one single session, you do the CT angiography and then here a PET quantitative perfusion imaging. And then you can color code the myocardium into individual CT scan to see how the perfusion is distributed during stress. And you see the images are created in a way that the absolute flow scale is so that if the color gets to green, it's reduced. If there's yellow or blue, red, it's normal, and blue is severely reduced. As you can see in this patient, there's only minor reduction in the flow. Here, in another patient, huge area of ischemia with a pretty similar anatomical disease. Even further, the combination is really helping what to do with the patients. For example, here we have another patient with an advanced 3-vessel disease based on the CT angiography. You have lesion here, LCX looks bad, LAD lesions looks very severe. If you look about the invasive angiography of this patient, it's a very good match. But if you ask what to do with the patient, that will be a very difficult question because which one of those lesions are functionally significant? And then combining the anatomical imaging with functional imaging here, you can see, okay, the culprit lesion in this patient is RCA. There is milder reduction in LAD region, but the lateral wall is normal. So this helps to guide, okay, you likely go to RCA PCI rather than CAPIC in this case. Another case, even more specific. We can now look even the small branches, like here, you have an LAD disease in different phases of LAD, parts of your several stenosis in row in LAD and RCA, and we can see that the right side is absolutely normal, but then there is ischemia here in the distal LAD region. And it's perfect correlation with FFR. We have done a trial comparing this, and you get almost complete match by combining anatomy and function with invasive anatomy and function, not against only the invasive anatomy. So we have had a lot of challenges in the functional tests in the past, and these challenges are listed here. The left main disease is, of course, very difficult to identify based on only the functional ischemia findings. Balanced 3-vessel disease is maybe problematic occasionally because the flow reduction may be completely homogeneous global. Multi-vessel disease, usually it is detected, but the severity is very commonly underestimated because the most severe lesion usually is detected, but the less severe lesions are not because you just use a functional imaging. Then the anatomical location, of course, the function you cannot get. You cannot identify non-ischemic coronary disease. You see only those which are functionally, obstructive lesions. And all those lesions which are there but you're not causing yet ischemia, you cannot detect from the ischemia imaging. And of course, microvascular disease is a problem. Now I've listed here the hybrid imaging combining CT and function will solve about half of those problems. What do we do with the other half? That's another story, but I will tell you it a little bit later. If I compare the combination of anatomy and functional imaging, now using PET-CT as a technique against invasive angiography and FFR, as you see, we get almost perfect match. If I look at the techniques alone, you have some limitation. With the CTA, you overestimate the stenosis. The positive predictive value is less good. It's suboptimal. With the PET, the functional test, you cannot separate the microvascular other causes of the reduction of flow from the epicardial disease. And there you need the combination of anatomy and function. What we know about the value of this combination in prognosis? There are increasing number of studies showing that if you add anatomical information or if you add functional information over the anatomy, you will have better prognostication of the patient. If you have both abnormal, the prognosis is worse. And also it has been shown that if you add the more information, you have more prognostic power. This is another study showing the same thing, but if you have a normal, you have unmatched one of the modalities is abnormal and both are abnormal. So much more power in the prognosis having both modalities combined. This study is from Zurich, and they investigated how much this hybrid imaging will impact on the downstream resource utilization. And in their trial, they found that about 50% of the patients, 45% had invasive angiography after the hybrid test. But even more important, when they looked about what happens after they get the cath, so the coronary artery disease in the cath was in 96% of the patients. If you look about the general population, without using hybrid imaging, 39% have coronary artery disease when you have invasive angiography. And then what happened after the catheterization? Actually, 86% of the patient had a revascularization, and normally this is 36%. So it seemed to have a big impact how you then treat the patient after having a good non-invasive information available. The other paradigm which I want to introduce here is that now this is the classical ischemic cascade where we look about hypoperfusion and then finally we get ECG changes and angina. Now the trend is that we are also looking more about the preclinical atherosclerosis and also the lesions which are not yet causing ischemia, those non-obstructive coronary disease. And there, of course, the combination makes a lot of new information. This is one of the studies which was published about showing what kind of findings you have a completely normal perfusion functional test. What kind of CT angiography findings you can see? Okay, majority of the patients likely have a normal coronary, this panel A here. But there are a lot of those with the plaques there, but not functionally significant. There are soft plaques found, and even sometimes left main findings. So all these kind of things you miss if you don't combine anatomy with functional test. What are the concerns? Of course, if you use more than one test, like sequential, if they are not, hybrid devices, then it's maybe become a little bit more complicated for the patient because you need to order another test. Now with a hybrid test, hybrid device, you can do everything in one single session. Our protocol takes less than half an hour to get the CT angiography and absolute perfusion. So it's very, very good if you have the device, but not everybody has such a device. Then you have another challenges for the logistics, how to deal with these kind of processes when you need to look about the patient between the two scans. Higher workload, the image analysis is not yet standardized, maybe a little bit higher radiation burden. Now this has gone down dramatically during recent years. I don't believe this is a major issue. Of course, we have less evidence that the cost effectiveness of this kind of approach has not been yet so. The final thing I would like to emphasize is that The other problems what we have had with the perfusion imaging can be solved by applying absolute quantification. I don't have time to go to details how you do it, but this is now possible to do it in routine manner. We have analyzed this by performing the quantification, and of course, the most benefit you get to patients with the multi-vessel disease, because you, as I explained, you usually detect the most severe stenosis, but the others may also be significant but non-detected. So you underestimate the disease severity. So if you do absolute quantification, your accuracy will clearly be improved after the quantification. This is also showing the ROC curves. And the good thing here that because the absolute flow itself is as good as the flow reserve, you don't need resting image at all. You do only stress in those patients without previous MI. So that makes the protocols very, very short, as we do it less than half an hour. The limitations are also obvious with the quantification. If you don't have the anatomical information, there are a lot of patient groups where there are sort of reduction in absolute flow in myocardial without epicardial disease. That's quite a natural thing to think. Patients with heart failure, patients with advanced atherosclerosis, but no really yet obstructive disease in the epicardial vessels, and also patients with the microvascular disease. So here, if you combine the quantification, you also need the anatomical information to really understand the situation. And finally, I've been using my time mostly of showing how this is routinely done using a PET-CT system, but there are other alternatives. This is one of those. We have done a trial where we used transthoracic echocardiography to look about the flow profiles in the lesions which have been detected by CTA. And we found this is performing also pretty well, not as well as the previous technique, but also is available to everybody to look about the coronary flow if you are skilled to do that. There is possibility, not in the same scanner, but afterwards, to combine CTA with the CMR perfusion, like this is the case report from Zurich. Now, it may become also possible to do the perfusion using CT. In this Congress, there are a lot of those presentations, but to be honest, this is really early era of the work. It's not proven that you can use CTA perfusion accurately. There are some nice cases showing it works, but it doesn't mean that in the real life it would work. But maybe in the future you can apply the CT to do the perfusion, don't need the hybrid device. Also, maybe in the future the combinations, new combinations which are now coming available and increasingly used in other fields than cardiovascular imaging can be also used in cardiology, like PET-MR. Almost every PET center today is buying PET-MR combination. So there will be possibility to do something which is never thought before. One of the things also in the future is that getting beyond the epicardial disease and perfusion, there's a lot of potential in the molecular imaging field. I just show here one of our own targets to be able to identify the vulnerable plaques non-invasively in the coronary arteries. And now we developed this kind of dual-caded PET-CT technique, and our preliminary result shows that in 80% of the patients, we can identify hot plaque in patients with ACS. We don't know what does it mean, but it's feasible. It's possible to detect these hot plaques in your coronaries in patients. So that's also, it's obvious that we need a lot of more work to really understand what these kind of findings would mean and to understand what is the incidence and such things in the future. Thank you very much.
Thank you, Dr. Knutti, for such a marvelous presentation, and I think that the session is open for discussion.
Everything is clear.
I would like to ask the audience any questions regarding this so interesting presentation. So, can I ask you a question?
Yes.
Oh, it's a question, please.
Johanni, thank you for a very nice presentation. I wonder if you could comment briefly on the economics of fusion imaging, PET-CT, and its potential application in the real world, as it were, rather than a very specialist imaging center, because although you produce beautiful images, which I'm sure are very useful for clinical management when the tools are available, I think we're very far from having these available in most cardiological centers.
Yeah, that's true. If you talk about the finances first, there are two components of the price of any test. Usually how much it takes time, and then of course the equipments and the tracers and the contrast agents you need. And now because the protocol is very short what we use, our price is actually lower than SPECT. It's surprising because SPECT takes more time, so you need more staff, more camera time. So that if you do it like we do, it's not a problem of costs. Where these kind of studies are now done, increasingly PET is used in several places in Europe, but also especially in US where the tracers have become available. The main challenge is today for PET is the availability of the tracers. In US there is also another problem that the reimbursement of combination is much more limited and controlled than in Europe in many places. So that also slows down the development in US.
Johanni, thank you for this elegant presentation. Actually, I want to ask about your opinion about the future in the coming 5 to 10 years about the nuclear cardiology. Are you expecting the hybrid imaging, for example, PET-CT, PET-MRI, is going to replace the traditional SPECT studies? Or what do you think?
Yeah, that's a very good question. I'm not really able to predict what really happens. What I can guess what happens. I mean, what happened in our center when we started this, people thought that, okay, we'll stop using the other, but it's not the case because we have a lot of different other populations where CTA is not needed. Like if you have a known disease or previous MI or previous CAPITS, PCA, there the question is only whether there's functional problem. Then you use functional tests like SPECT, stress echo, MR, whatever you have been using earlier. So this kind of combination is great for patients with suspected disease as a sort of not primary, the first step, maybe exercise test, but after that you can do imaging test. And this is very powerful because it gives you immediately the answer whether there's disease, what vessels, how severe, what kind of ischemia. But the other populations, we still use standard techniques.
Thank you.
Can I ask regarding your presentation about the hybrid PET-CT? Nowadays is possible. It's not common, but it's possible to use the CT to analyze the FFR. What do you think if you compare the both techniques?
Yeah, there are coming now data about the comparison of CT-derived FFR versus invasively derived FFR. Without knowing the data, I would say that I would not believe this is going to work because it's just based on anatomy. It's just a trick to mathematically calculate something, what is happening, because you could do that invasive anatomical imaging also, but nobody uses it. So I don't believe that looking at the lumen, you can really get the function. You don't know about the collaterals. You don't know what the area of supply that vessel is doing. So there's a lot of missing data from that. And I've seen now a couple of real analyses comparing, and there's a huge scatter. So I don't personally believe that this system works. That's my answer.
So shall move on.
Thank you very much, Johanni Knuti, for this excellent presentation. I'd like to welcome the next speaker. It's Professor Cook from Hamburg, Germany, making a presentation on leadless pacemakers and subcutaneous ICDs. Welcome.
Dr. Ribeiro, Dr. MADSEN, ladies and gentlemen, it's also my real pleasure to join this multidisciplinary session. It's a new experience for me too, but I like it, because you get the chance not only to talk to your friends and colleagues, but to get an insight into what other people do and learn. So these are my disclosures. Now, if we talk about leadless pacing and subcutaneous ICDs, we should remember that the weakest link of a pacemaker or an ICD or a CRT device is the lead. And the more leads, the more complications. Now, if you look to the potential list of lead problems, it looks quite frightening, but it simply reflects the truth. So you have problems that are clearly directly related to the lead. You have problems that are related to the placement of the lead. And then, of course, you have long-term problems such as vein thrombosis, valve injury, particularly injury to the tricuspid valve, of course. And there's increasing evidence that maybe lead thrombi may lead also to pulmonary hypertension. And that list definitively will not be complete. Now, let's go back a couple of years to the very first study that we did initiate with ICDs, which was the CASH trial. It was the very first randomized trial with ICDs that was ever done. And then this trial was used to start the AVID trial and the SIDS trial. But CASH was the very first trial. And it was this trial to show that there was, for total mortality, a benefit in patients. For secondary prevention, this was only secondary prevention, of course, compared to amiodarone and metoprolol together. And it was interesting, I'm not going to details, that there was no difference between the amiodarone treated arm and the metoprolol arm. So we put it together at the end of the day. And as you can see, after the first year was a risk reduction with respect to total mortality of 41%, second year 40%, third year 30%, fourth year 30%, and so forth. So if we look, of course, into the mode of action, how does the ICD work? It really did what it was supposed to do. It reduced sudden cardiac death in a significant fashion, as you can see here, with an extremely high reduction of risk compared to the control group. Now, it was interesting for me to see, as the guy who started this trial many, many years ago, that most recently the group of Dr. Scharley from Leiden was taking all the studies for secondary prevention that were initiated in these early days. And as you can see easily here, most of these early trials were using a combination still of implantation of leads via a thoracotomy and non-thoracotomy in some of these patients, whereas the more recent studies than later studies were just using leads that were implanted via the veins, and this is also true for the CRT systems, of course. Now, if you look to the in-hospital mortality, then the in-hospital mortality was significantly higher, of course, at the time when we had to open the chest to put these leads in, compared to more recent data from these big randomized trials. So today it was total 0.3 in the CRT population, 0.2 in the regular ICD population, and it was 2.7, and the same was also true for 30-day mortality. So there was a significant difference in favor, of course, of transvenous leads. Now, what was also interesting, if you look to the incidence of pneumothorax in patients that underwent transvenous lead implantation for ICDs versus CRT systems, that the event rate was quite similar at 0.9% in all these big randomized trials. And if you look into lead dislodgement during follow-up in these studies, you can also see that the number was 1.8 for the RV leads and right atrial leads only, but if you add a left ventricular lead, then the dislodgement rate triples to almost 6%. So all this is well known, but it was just nice that these guys did this type of analysis based on the randomized studies. So most recently there was another interesting publication that came from Johnny Poole, which I like a lot. So this data come from the RIBEIRO registry, and the RIBEIRO registry was looking into patients that had to undergo a replacement of their device. And they looked into one group without any additional lead that they wanted to add to the device that was already implanted versus a group that got at least one additional lead. Now let's first have a look to the complications of patients that just got a replacement without adding a lead. And if you look to the peri-procedure complication rate, it's extremely low. Now if you look to subsequent follow-up, then you can see that the overall complication rate, at least one major complication, is in the range of 4%. Now, if you add one lead, if you add at least one lead, you can see that there is a significant increase in major complications, and over time, you see that the number goes up from 4% without adding a lead to almost 14% if you add at least one lead. So you update the device to a CRT device or from single chamber into dual chamber, and you find this typical complications, lead dislodgements, malfunction, prolonged hospitalization, hematoma, and of course the death rate increases with each lead at the end of the day that you add to the patients. Now, if you put all these data together, then you can easily appreciate that the overall complication rate, if you upgrade to a CRT device or you revise a CRT device, is in the range of 18% versus you upgrade a single ICD or pacemaker or dual ICD pacemaker, or you revise it, it's only in the range of 10%. But if you don't add any lead, then the complication rate is only 4%, which leads to the conclusion from the authors that pacemaker and implantable cardiovascular defibrillators, generator replacements, are associated with a notable complication risk, particularly those with lead additions. These data support careful decision-making before device replacement when making device advisories and when considering upgrades to more complex systems. So I think this is really something, particularly in elderly patients, that we have to keep in mind, that even upgrading the device increases the risk of major complications from around 4% to 14%. Now, we are also aware that most recently there was a release from the FDA that was notifying that some leads that are at this point in time implanted from St. Jude should be followed very carefully because of some potential isolation problems. It simply indicates, that these informations come on a regular basis and they are true for almost all of the companies. It's just the most recent one, and I just wanted to add it to this presentation because it was just published a few days ago. So lead issues are severe issues in the clinical practice. And if I want to summarize this from the overall data, we know if we implant devices, the pocket hematoma is in the range of 5% increased when using heparin. Lead dislodgement is in the range of 0.5% per lead. There are chronic lead problems, as have been addressed. I don't want to go into this more in detail. There's erosion through the skin due to the pocket, 0.4% after the first implant, which increases after replacements. You have infections, 0.2% within a year after the procedure. Up to 5% of all the people that have endocarditis are due to infections of the pacemaker or the leads. There is also a certain risk in the range of 1% of deaths and 2% of major complications if you extract the lead, so that also should be kept in mind. And that's the balance that you have to keep in mind if there is the potential for lead malfunction or failure. To take these leads out. It's not without risk that we can take leads out. As you can see, there is interaction with the vasculature and heart structures. I mentioned that before. The tricuspid regurgitation, venous stenosis, thrombosis, SVC syndrome, cosmesis, and so forth. Now, we know that lead failures do occur up to 21% over 10 years after the implantation. And we also know that lead replacement is mandatory in almost 40% within 8 years after ICD implantation. So this, of course, all these potential problems that we are facing with leads has led to the idea of developing an ICD that does not use a transvenous lead, but is connected via a subcutaneous lead. and hopefully in the future will lead to pacing without any lead even. Now you're all aware of the work that Gasbardi and my friend Riccardo Cappato, who was working with us for more than 10 years, they are the two guys that developed the idea to introduce a subcutaneous defibrillator. And I think, to be honest with you, it's a great idea. It's a great concept. Now the question is the concept ready? And this is the question that was put forward to be transferred into the real everyday world for all of our patients. Now this is an example of such a subcutaneous defibrillator. You see the lead, the percutaneous lead, which is in parallel to the sternum, and the device which is implanted at the lateral thorax wall. And you see it detects ventricular fibrillation, and it shocks and it terminates the ventricular fibrillation. Now they have tested in a very nice series of experiments, animal experiments and human testing, various lead configurations. This comes from this study, and finally figured out that this configuration was the best. And if you look into the energies that are required for termination of ventricular fibrillation in this configuration, it was significantly lower than with any other of these configurations, but still significantly higher as compared to transvenous ICD termination of ventricular fibrillation. So there is no question the average energy that is required is in the range of 32 joules, which of course is significantly higher as what we are used today if we are using transvenous termination of these arrhythmias. So this is an example, as you can see very nicely here, the onset of a ventricular tachycardia, a very fast ventricular tachycardia at a rate of 270 beats per minute from this New England Journal paper. The device starts to trigger the ventricular tachycardia. It's indicated by the T. The T says it's a tachycardia, so it's sensing, and it identifies this rhythm as a ventricular tachycardia. The C stands for charging, so it's charging for the second time. You can see here it starts charging here. There's a control, charges and delivers the shock, 80 joules, and then VF is terminated. Now again, this is the device. This is the lead. You see the proximal electrode here, and you see a distal electrode there. And I will come back to this configuration in a minute because it's used constantly for 3 different vectors for sensing of the underlying rhythm. Now the first study then, the European trial that was published with the same paper, consisted of 55 patients. It's a quite normal ICD patient population with an ejection fraction of 34% on average. And as you can see, interestingly, 70% of these patients had underlying coronary artery disease, 20% dilative cardiomyopathy, and some other conditions. 80% was implanted for primary prevention and 22% for secondary prevention. Now, when these patients were followed over almost 1 year, you can easily see that the device did what's supposed to do. So 2 consecutive episodes of induced arrhythmias were successfully converted at 65 joules. So that was the criterion to go ahead and move ahead for the implantation. And after 1 year, 98% of the people were still alive. 12 patients had complications, pocket infection, minor lead migration into parasternal lead dislodgement in 4, oversensing, inadequate sensing in 4. So it's not to believe that also this type of lead, of course, doesn't lead to any potential lead problems. And we have to see over time if this type of device is used more in regular clinical practice, how this will change over time and what the direct comparison with transvenous leads actually will be. Now, interestingly, a total of 12 episodes of spontaneous VT were detected and successfully treated in all 3 patients. So again, these numbers are low, and we have to be extremely careful at this point in time to make any general recommendation. Now, there was an interesting paper that is indicating already again with a rather small number of patients. It's the Brompton experience that was most recently published. And they were looking into a group of patients where they took the team decision to finally implant a sub-Q device. Now, as I mentioned before the device can be implanted, there are some recommendations that come from the company that you have to do testing, whether the vector, and it's mostly the R to T ratio that counts. And you have to test this ratio, and as you can see in this example, you have 3 vectors from the distal electrode, sensing electrode towards the can, from the proximal towards the can, and between the 2 electrodes. And they are continuously monitoring the R to T ratio before the decision is taken to deliver an impulse. And before you do this, you have electrodes that you can position in the supine and up position to test whether this ratio is suitable enough to do the implant. Now, the colleagues from the Brompton Hospital were following this advice, and they looked into a series of 16 patients, young patients and older patients. As you can see, actually, the population in total was very young because they thought that this would be an appropriate patient population with channelopathies with a rather low risk of developing ventricular fibrillation and ventricular tachycardia, most suitable for such a device. Now, if you look over time, what they found is out of these 16 patients, 3 patients received shocks, and for appropriate interventions, VT, VF, this is indicated here. And however, 4 patients received shocks for inappropriate events. And I just would like to show you an example. Again, this was after careful testing and that the device would work appropriately. This is an example of a sinus tachycardia, as you can see, but the device starts here to detect and to trigger a tachycardic event, a ventricular tachycardia, so the T is indicating that the device believes this is a ventricular tachycardia. It charges here, and finally also charges there, and it delivers the shock during sinus tachycardia. So this is a typical example of T-wave oversensing in one of those patients. Furthermore, what they also observed is that the appropriate shock in 2 out of the 3 patients was delayed by some noise sensing. As you can see here, this patient clearly has ventricular fibrillation. This started even 2 seconds before this recording was taken. You see at this point in time, it's identified as an underlying ventricular tachycardia rhythm, but then the device says, no, it's noise. So it stops to look into this, and it's restarted only over here. So the shock is delayed in this particular case when it's delivered, but it terminates, as you can see, successfully, ventricular tachycardia, ventricular fibrillation in this particular case, but the shock was delayed by a couple of seconds. Now, if you look into the overall experience of 9 months, which is still rather short, 3 children required reoperation, 18 clinical shocks were delivered in 6 patients. As I mentioned before, 10 shocks in 4 patients were inappropriate due to T-wave oversensing. Within the 8 shocks for ventricular arrhythmias, 3 were delivered for VF, among which 2 had delays in detection with time to therapy of 24 to 27 seconds. So what that means, of course, over time, really requires further investigation. I think it's just a word of caution that, of course, at an early stage of such a therapy, which is more or less an early generation, we can't compare and we can't expect that it works as nicely as the 10th generation of 15th generation that has been introduced today for transvenous defibrillation. So what is my recommendation before I would recommend that everybody should undergo such a device implantation? Of course, we know there are limitations. I would like to see that the DFT drops. I would like to see, and this is what we were asking for, the guys of the early days of the ICD, the sensitivity has to be 100%. We can't miss a single event of ventricular fibrillation. And we should not allow noise to prevent the ICD at the end of the day to shock the patient. So VT-VF sensing is extremely critical to me. Of course, the device at that point in time is not designed to detect arrhythmias below the rate of 170. It's a shocking device only. It doesn't pace, it does not deliver ATP, it does not allow CRT. So I would love to see, and I know there's a small study starting now, a randomized study comparing the transvenous ICD, even for primary prophylaxis versus the subcutaneous ICD, to figure out what are the appropriate patients. So today, there are potential patients. This is a rather long list. I don't want to go into details for time reasons, but mostly, of course, we are looking into patients that have potentially a low incidence of these events or had potential complications, or maybe are going into heart transplantation where you want to preserve vascular access. So there are a couple of issues that even now should be considered. So let me just move very shortly into the leadless pacing. There is, of course, reduced invasiveness, improved efficacy, and more cost-effective therapies. However, there are also potential risks that we may face using these devices. The most challenging one for me is the battery exchange at the end of the day, but fixation, dislodgement, perforation, potentially, there are some others. I just would like to remind you that the idea of a leadless pace was already introduced in 1970 by Dr. Spickler. He was talking about a nuclear battery in these days, but it looks very similar. It's finally a capsule that is left in the apex of the right ventricle. So this is an old idea. I don't want to go into details. There are 3 systems tested at this point in time. One is working with induction technology. It's a German group. Dr. Wienecke is the leading author here. I just give you an example. You see this magnetic field that is produced outside of the heart, and then you have the receiver that is transforming this magnetic field into electrical energy. But this is an early stage. This is an animal experiment. Of course, there's no first in man yet. The second system is using ultrasound. That's the system that Debbie Ashe has introduced into the market. So you have an intracardiac receiver that converts ultrasound from the transmitter and converts it to electrical energy. A couple of patients have been tested. A study has been started. So the receiver is 9 millimeter plus a small lead, as you can see here. The transmitter is implanted over the apex, and it's connected to the battery, which is implanted in the abdomen. So the YCRT study, which was adding this device in patients that were upgraded to a CRT, so the device would be implanted in the left ventricle to allow CRT pacing, is presently on hold after implantation of 11 patients because of some complications that were encountered. So finally, there is a completely implantable device that is shown here, which has been produced by one of the larger manufacturers. It's a 20 French application device, 24 millimeters in length. It has a 7 to 8 year longevity, and it's implanted via cerebral catheter, as can be shown here. So there are some animal data using this device. I just would like to remind you again that there could be potential benefits, at least no lead fractures, because there is no lead. There are some other potential benefits of such a system. I just want to show you some of the animal work. There were some chronic sheep models, 16 animals. The device was implanted. So you see the device implanted here. There was no acute complications. And finally, what they could demonstrate from this animal work, there is no first in man yet. Hopefully the first implantation in man will be done before the end of this year. But as you can see, the pacing threshold was extremely stable over time. This is 180 days of follow-up. And also the sensing of this electrode, the R-wave sensing, was in the range of 4 millivolts, which is quite similar to what we can expect also from transvenous leads. So in summary, ladies and gentlemen, I think both technologies are quite interesting, but it would be too early at this point in time to make a general recommendation that everybody should undergo subcutaneous ICD implantation, even not for primary reasons. I think we need more data, we need registries, everything is underway. The company is very carefully collecting these data, and I think the future of pacing, of course, will be leadless pacing. Of course, it's a primitive device, it's RV pacing only, and we have to look into more sophisticated devices, but I think we have to accept that early experience can only be done with premature technology, and the time will show that these technology will develop in the right direction. Thank you very much for your attention.
I think in the interest of time, we have only time for one question, if somebody has a question. Yes, please.
Thank you very much. Just wondering, in terms of the patients who received shocks with the subcutaneous ICD, do you know what the psychological impact is, obviously, with the higher energy?
Actually, all of those patients received the shock, and they compared it. Some of those patients had previously transvenous ICDs, and the patients' comments were that they didn't feel the difference. You know that pain perception is very subjective, and we also know that some patients that receive a 4-joule shock have the feeling it's a very dramatic event. So there is no direct correlation between the high energy shock with the data that we have now. So of course we need larger studies, randomized studies, to finally make a conclusion here.
So now Dr. Professor Westerby from Great Britain will speak about new left ventricular assist devices. Please.
Good morning, and many thanks for including a surgeon in this very distinguished audience. There is a vast amount of new technology now in the left ventricular assist device field. So we're now switching to very advanced heart failure. And in both the United States and Europe, there are about 7 to 7.5 million patients with heart failure. If you bring this down to severe heart failure, about 150,000 patients in Europe and in the US have severe heart failure and are under the age of 65. If you consider that in both countries the number of cardiac transplants are only around 2,000 to 2,200, there is an enormous gap between young patients that you can treat with transplantation and the population. And the FDA recently in the States predicted a need for 44,000 long-term blood pumps in the USA per year. Sorry, can we get the slides up? There we go. Thanks. Yeah. So 44,000 blood pumps per year in the US alone, and these blood pumps currently cost the same as a Porsche car. Now, the best Porsche car. I think we're on the move now anyway. Let's start with how cardiac transplantation looks, because it's been said to be the gold standard for the treatment of advanced heart failure. But that's like saying the gold standard is like a lottery win. Very, very few patients can have a cardiac transplant. Currently, the median survival for cardiac transplantation is 12 years. But the waiting list mortality is up to 10%. The 1-year mortality is 15%. And by 10 years, 58% of the patients have died. If you look at those that die before 10 years, surprisingly, the mean survival is only 3.7 years, and you can demonstrate survival advantage only for the so-called UNOS status 1 patients. And Mario Deng, who's sat on the front row, helped show this. I'm having trouble with this. So predictors of transplant mortality are age less than 55, longevity are age less than 55, and no metabolic risk factors, and you need to get a young donor with a short ischemic time. Predictors of poor transplant outcome are essentially the metabolic risk factors, obesity, diabetes, hypertension, renal impairment, and the need for preoperative ventilation. And if you get a borderline donor heart, which is more and more common, the outlook is not going to be good. Now, let's just look at the current survival of the contemporary rotary blood pumps. The Jarvik, the HeartMate 2, and the Heartware VADs are now used commonly, particularly in the United States and in some European countries, certainly not in the UK because our National Health Service can't afford it. But we are now achieving reproducibly 5-year survival with these VADs. The best survival is actually my first Jarvik patient who got to 7.5 years. But the other pumps are now reproducibly doing well. So you can now actually predict which patients should have which treatment. So for cardiac transplantation, the evidence base suggests it needs to be the young patients, less than 55 years of age, very high urgency status, with low pulmonary vascular resistance, low BMI, no diabetes, renal impairment, or right heart failure. Whereas for the LVAD patients, you can treat them more satisfactorily in an elective way when they're in Intermax status 2 to 7. You can treat patients with high vascular resistance, high BMI, diabetes, some renal impairment, and so on. So these are now very distinctly two different patient groups. What about the pumps themselves? I'm going to move through the current technology and show you some future technology. What we're now talking about is hopefully the equivalent of an off-the-shelf cardiac transplant, because the pumps are doing better, the complication rates are lower. Not enough cardiologists realize this, I believe, and I think we have to move forward because the pumps provide excellent relief from severe symptoms in heart failure, and more they're improving longevity. Now, the Thoratec HeartMate is widely used, and several thousand of the pumps have been used. And since the early rematch trial with the HeartMate 1, the big pulsatile device, survival is getting better and better and better. If you look at the medical survival over 2 years versus the survival with the continuous flow VADs, there is a very substantial improvement in survival with a blood pump. As time has gone on with the HeartMate 2, the continuous flow rotary blood pump, the incidence of hemorrhagic stroke, device-related infections, sepsis, and so on is going down. And this is because experience is improving the way we manage the patients. So now if you look at the historic rematch medical patients versus the rotary pump destination therapy patients, we're getting much better survival. And now in selected programs in the United States, the survival with a blood pump is as good as the survival with cardiac transplantation at 1 year, and is rapidly approaching the result of transplantation at 2 years. Thoratec with the HeartMate 2 are moving towards a completely implanted device without a percutaneous driveline. The reason for this is the driveline bringing electricity into the body through the skin is an infection risk and one of the Achilles heels for long-term mechanical circulatory support. With the big pulsatile LVADs, the incidence of driveline infection was virtually 90% within a year. And when sepsis involved the pump itself, either the pump had to come out altogether or the patient would inevitably die. So fully implantable systems are desirable. Smaller systems are desirable, and Thoratec are moving towards a small implantable rotary blood pump. As you see, there's a design freeze on this now. It's in animal studies. It's a magnetically levitated VAD and probably an improvement over the HeartMate 2. Myself, I've used the Jarvik 2000 for many years. We can only, in the UK, use these pumps with charitable money. The National Health Service doesn't pay for them. But there have been improvements to the Jarvik 2000. Jarvik improved the bearings and various other issues, and with the original pump we achieved survival to 7.5 years. With the newer pump we're pretty certain that it's going to be even better. One of the innovations we came up very early with in Oxford was a different way of avoiding driveline infection. If you put power into the head, like Frankenstein, you do not get driveline infection. Why is that? It's because the scalp skin is highly vascular, there is little fat, and if you screw a skull pedestal into the head, into the skull, it doesn't move, and that prevents infection. And these are two of my early patients with the Jarvik 2000. You cannot even see the skull pedestal once the hair has grown back. So that was an innovation which I think will increase now and is an improvement. One of the earliest pumps was the Micromed pump, very small pump, but with a long inflow cannula. And I have to say an inflow cannula is a risk factor. It's a risk factor for thromboembolism, but again, Micromed are producing a smaller pump, and Berlin Heart, right here in Germany, have had survivors with their pump to 6.5 years, and everything is improving with fine refinements of the design with time. Currently, one of the pumps really on the increase that's only been used for just over 5 years is the Heartware VAD, which is a small device that fits entirely within the pericardial cavity. You don't need a cavity within the abdomen to house the pump. And this pump is doing particularly well. I'm using this pump in Greece together with autologous bone marrow stem cell therapy. And some of the original devices are still working well without thromboembolism. We're getting 85% 1-year survival, the same as cardiac transplantation, and virtually 80% 2-year survival with this device. Because this device is small, it's been used in patients that also need right ventricular support. So here are patients who have pumps in the right ventricle and the left ventricle, and some where the right ventricle is small but still is failing. You have to put the pump in the right atrium. But these combinations are alternatives to the total artificial heart. None of the total artificial hearts currently are satisfactory for long-term use. They're only satisfactory for bridge to transplant. But with these biventricular systems, there is difficulty balancing left-sided flow and right-sided flow because of the difference in systemic and pulmonary vascular resistance. And also, with time, the right ventricular cavity shrinks and the inflow cannula of the right-sided pump tends to impinge on the septum. We have ideas to overcome this, and very specifically ideas for more user-friendly total artificial hearts based on 2 rotary blood pumps. This is what a dual system looks like. The amount of battery power and so on that you have to carry is not prohibitive in comparison to the current total artificial heart systems. Heartware are now trying to move to an even smaller pump, a pump that's a little less smaller than the Jarvik 2000, and this device, the MVAD, is currently being tested and is about 1 to 2 years away. Terumo have quite a large device that I tested in the animal lab many years ago now, and we had this Terumo magnetically levitated centrifugal pump in sheep without any anticoagulation and without any thromboembolism for up to a year. The one thing clinically about this device is it tends to be rather large and bulky, but there are survivors again to 4.5 years. This is a very small pump that takes blood from the left atrium and pumps it into the subclavian artery, as you can see. But I think because the venous inflow is low pressure, there have been problems with thromboembolism with the Circulite device. Lastly, because the devices I've shown you have cost the same as a Porsche car, very good German car, I would love to have one myself, but can't afford it, the patients can't afford the current pumps. So in the UK, I got a group of motor engineers together to try and devise an affordable LVAD. And in short, we have, with an innovative design, it's called Calon because the group is based in Wales, and Calon is Welsh for heart. This is a very small pump with a lot of design features. It tells the hospital what it's doing. It tells a wristwatch what it's doing so the patient can see how it's performing and so on. And the clever thing about it is the motor for this pump actually sits in the inflow cannula. So the amount of pump outside the heart is really, really tiny. So this will probably be the smallest LVAD when it's introduced, hopefully in about 2 years' time. So the message is pumps are getting more user-friendly, more sophisticated, safer, with less thromboembolism, less infection, but they're still not affordable for most healthcare systems. So that's the last thing to address. However, I think the interesting aspects of the pump work is the way forward. This is a patient in Greece, where with my trainees we've been using a combination of pumps with stem cells. So this patient was in hospital for 3 months in an intensive care unit with severe heart failure. He already had biventricular pacing. He already had an implantable defibrillator, and he couldn't put a leg out of bed. We put in a Jarvik 2000 and injected him with his own stem cells, including the mesenchymal stem cells CD105 that doesn't normally exist in native myocardium in adults. Now, the interesting thing was, with this so-called myocardial regeneration therapy, when the patient died 2 years later, we got his heart and got it to a very good pathologist at the Royal Brompton Hospital. And actually, when we looked at it with CD105 immunohistochemistry to look for new vascularity, to see whether the stem cells had influenced the hibernating myocardium, to our great surprise, we found masses of new capillaries, which we'd seen on thallium scanning before the patient's death. But these new capillaries were CD105 positive. We've looked at controls, we've looked at other LVAD patients that haven't had injection of autologous bone marrow stem cells, and they do not have these CD105 positive cells. So what we think at the moment is that so-called myocardial regeneration therapy, offloading the native failing heart with a pump, but treating it with various cells, is a way forward. Because when the native left ventricular function improves, the propensity for longer survival improves, and the propensity for thromboembolism falls because you lose the problems with akinetic myocardium. So, a brief overview, the pumps are getting better, the patients do well, they're user-friendly, they're too expensive, but we have ways of dealing with all of that. But I think the smart money in the future is going to be the combination of pumps with other types of therapy to improve the native myocardium. Thank you very much.
Thank you, Professor Westerby. Let's hope that the prices can come down to treat these kind of patients.
To cheap British cars.
Yeah, for sure. So this is open for discussion. I don't know if there is any question. Please.
Thank you very much. You've made a convincing case for the potential scope of these devices and also shown us that there's a huge variety both existing and being developed. Could you comment, please, on the requirements of the different regulatory environments that exist? And from a clinical perspective, what degree of evidence, in what context, such as randomized trials, do you think we need to have before these devices can be released completely to the market?
The regulatory authority issue is difficult, and it's different in every single European country. So that's not a question that's easily answered. In the United States, the FDA are very keen on pumps now because it keeps patients out of hospital with their heart failure and prevents some of the massive costs of recurrent hospital admissions for stabilization. The FDA did predict, however, that if all the patients with advanced heart failure that they think need pumps got pumps, it would account for half the national heart failure budget if the prices don't come down. Where do the clinical trials need to go next? Well, we know the pumps are effective. The complication rates are coming down. I think the next thing is to test the smaller user-friendly pumps against cardiac resynchronization therapy, because in very advanced heart failure, New York Class 4, a lot of resynchronization therapy has been done, but the patients are not feeling that much better with it. So I think we've got to move to comparing pumps with resynchronization as the next round of clinical trials.
Wondering if you could comment on pulse-style devices, especially in view of the long-term complications of the pulseless devices. Do you think the days of pulse devices are over, or are we going to see a second generation of pulse-style devices?
The answer is the pulse-style devices did disappear. In the United States, the last HeartMate XVE pump was put in several years ago. I did a lot of work with large mammal models looking at the influence of long-term non-pulsatile flow and what happens when you put these devices into human hearts with severe heart failure. The thing is, these patients with non-pulsatile devices do have pulse in the circulation. The reason is that the native heart improves with time and pulsatility is transmitted through the device. So I think the answer is we will not go back to pulsatile devices. I think the miniaturization and the non-thromboembolism issue is where it's all going. But the myocardial regeneration therapy, I think, is the next industry in heart failure, because we are showing that stem cells create new vascularity, which improves the function in hibernating myocardium. And I think this is important.
Just a quick comment regarding the quality of the presentation. We have some congratulations, so it's great. And one question of one colleague from Portugal is is it acceptable and cost efficient to implant a cardiac pump at 75 years of age?
It will be demonstrable that these pumps are cost effective in the elderly for the reason I stated, that the pumps will provide good symptomatic relief and keep the patients out of hospital. There is no upper limit to age for an off-the-shelf device. And in the United States, clearly, they're using LVADs now for patients up to 80. And they still get good results, good symptomatic relief, good quality of life. And most of the patients are only interested in quality of life when they get elderly, as opposed to length of life. But I think these modern pumps are now giving us both. They're giving us good quality of life, and they are improving survival. Thank you very much. Thank you.
Thank you very much for this excellent presentation, and I think we'll move on to the next presentation from Professor Vahinian from Paris, France, regarding future percutaneous therapies for mitral valve disease. Will they reach the TAVI success?
So, Mr. Chairman, dear colleagues, I'm facing a difficult challenge. Shall I do my talk or not? Because we are very far away, but I try to cut it as much as possible to stay in time. So, it's a big challenge. The question is here. Here are my disclosures. I was planning to discuss with you what is a TAVI success, but we don't have time. So, let's go immediately. No, I'm sorry, but, that's a fact. Huh? What is the situation of TAVI today? TAVI is becoming extremely popular because it is effective. There are complications, but they should be handled in the future. It provides good results up to 5 years. And you see in Germany, and Karl-Heinz can confirm that, the usage of TAVI is very high. Even the surgery is going slightly down. The good news is, thanks to TAVI, more patients, high-risk patients, are treated now. And if we can summarize, we can say that TAVI today is indicated in inoperable and high-risk patients with severe AS and severe symptoms. Research is ongoing, but no doubt, at least for me, the indication will be expanded in the future to lower-risk patients. Move on. Mitral valve. Mitral valve is not the same story. It's a highly complex apparatus with a lot of complex interaction. The surgeons apply fantastic recipe. You have a full meal with all the thing inside with ring annuloplasty and things different. It works extremely well. In primary MI, organic MR, high success rate in good hands, long-term is excellent. The situation is completely different in secondary MR, where the results are not as good. By far, surgery is not a gold standard. Why? Because we do not know with the chicken, with the egg. Definitely it's a disease of the LV, and probably the mitral valve is a consequence, a secondary player. What do we have to propose percutaneously? The only one we have available, at least in a rich country like Germany, it is a percutaneous edge-to-edge repair. This technique is trying to reproduce a surgical technique which was pioneered by Dr. Lillehei and Dr. Alfieri. It's a good technique in their hands. Unfortunately, there is not a good dissemination worldwide, and this double orifice mitral valve provides quite good results when it is performed together with annuloplasty. Without annuloplasty, results are less good, and it is a very strong predictor of unsatisfactory long-term results. Here is a device. It's a bright clip if you are able to put it at the right spot at the right time. It takes time, but you can learn. Even us, we were able to learn that with a good... with a good training. What data do we have? We have this randomized trial, the famous Everest 2, comparing the device with surgery, 200 patients, surgical candidates. What did it show? When you have the device surgery, it shows that there is more residual MR after this device implantation in comparison with surgery. There is more, and we know that having residual MR is not good for follow-up. What about the clinical result? If you look at the need for surgery, after surgical treatment in this randomized trial, surgery was needed in 4% of the cases, which is good. But surgery was needed in more than 20% in the device group, which is not good, not acceptable for a patient with a surgical candidate. But it's very good for a patient with not a surgical candidate, who is very high risk for surgery. And what happens in this randomized trial, like in our practice, patients fare very well. They are very happy with the result. They feel better. And now there is a very large expansion of the use of the device. It's more than 6,000. My slide is very old. It's March, 6,000 patients. But the problem is The patient where it is used are completely different from the patient in the randomized trial. They are definitely not surgical candidates, very high risk, and most of them do have functional MR, while in the randomized trial it was just the opposite. So I jump over that. What can we say from these non-randomized registries? Here is a European registry, 500 patients, which shows that the safety is good. Relatively low death rate when you think that the patients were very, very sick, few complications. MR is reduced, but still the majority of patients still do have MR2+. Patients fare very well. They are very happy, and majority of them have few or no symptoms. So that's very good news. But don't forget, non-randomized trial, relatively few patients, short follow-up, and no control for medical therapy. So let's say it's promising, but it doesn't prove the efficacy. To prove the efficacy, we should perform randomized trial. And with Karl-Heinz and other friends, we'll be part of this trial, which will be launched soon. It's a trial in secondary MR patient, heart failure patient, severe MR, low ejection fraction, optimal medical management, and if it fails, they will receive either the device or medical therapy. This is a European trial, and the same will go in the US. What is the current situation? You remember the slide show you from Germany, another slide from Germany for the MitraClip. You see exactly the same thing. It's catching up when you can afford, once again, but the effect for the patient is good because more patients are treated thanks to the availability of this percutaneous device. Now, a very sad story. Coronary sinus annuloplasty. Who can imagine, Karl-Heinz and myself, that it could be effective? If you go in the coronary sinus, you are not at the level of the mitral valve, and you don't cover the whole circumference. So lack of efficacy will be there. And you may well impeach the circumflex artery. So once again, go to the concept and you can predict the future. 3 devices were tested. 2 are abandoned, 1 is still there. For how long, I don't know. That is the level of evidence which is provided to us. Big series, 60 patients. Then attempted procedure, there are failures. And there are also temporary coronary compromise. Of course, you can retrieve the device. So there is still a technical problem. Which sort of effect on the LV function? There are p-values with many, many stars. What does it mean for a patient to go from 66 to 63 millimeter for LVEDD? I do not think it's very significant. What about the clinical findings? No randomization, very small number of patients, no control for medical therapy. There is an improvement, but what does it mean? Can we draw any conclusion from small series like that without randomization? No. What is next? There are direct annuloplasty device, 2 here, the mitral line, the GDS. We are trying to do either a localized application of the posterior part of the annulus or a subannular restriction. They are in clinical trial. Relatively few patients have been treated. It could be effective, especially this one, because it tends to reproduce a surgical technique. There are more interesting approaches for direct annuloplasty. Either this one introduced transatrially, where you have a predetermined diameter, this one, which is already in clinical trial, where you go transatrial and you screw the annulus here, and you cover from trigone to trigone. So you are going very close to the surgical annuloplasty, and the first patient has been treated surgically, and the first patient will be treated via a transseptal approach within a few weeks or months. Chordal implant. Chordal implant is a way to treat primary MR in many centers now. There are, at least to my knowledge, 3 approaches. These 2 are transapical, and this one is going transatrial. It's a very big thing, and they are already in clinical trials. But really the future. Remember the surgeons. Sometimes they are extremely wise, and Dr. Westerby, you are here. They are extremely wise. They told us, it's a complex anatomy. We should combine techniques. And we've done a case years ago with the previous edge-to-edge plus coronary sinus annuloplasty. But now we'll have available, they are already in clinical trial, device enabling us to combine ring annuloplasty and chordal replacement. But now, it's so complicated to repair the mitral valve. Why don't we replace it? And here is, let's say, the first one, the Cardiac AQ, introduced transeptally this special pattern for fixation without using too much radial force. Here you see the device introduced transeptally and the device released. The first in man has been performed a couple of weeks ago. We don't have any details, but it has been done. It is feasible. There are other devices, at least 3 to my knowledge, which are of interest, but there are many challenges. It will be difficult to position this valve. It will be difficult to fix solidly this valve. Paravalvular leaks will be an issue. It's not a real issue in aortic position, but it's a big, big problem having a very small paravalvular leak. If it is high velocity, it will create hemolysis. Valve gradient should be carefully looked at, and LV outflow tract obstruction could be a problem. What about thrombosis? And of course, what about durability? One case, no report. So, very promising, but now we should think another way. We are going to treat patients high risk with heart failure, etc. Why don't we combine this mitral device with other device like CRT? Here is a photo of a combination of coronary sinus annuloplasty with CRT, but more promising is the preliminary work from Dr. Oricchio and friends showing the use of MitraClip in non-responders, CRT non-responders. These poor patients, they have a terrible outcome spontaneously, and Dr. Oricchio and his colleague, in a small number of patients, but very sick patients, was able to show that there was a functional improvement and a decrease in the degree of MR, even if there is still a majority of patients with 2+. Once again, it's not a proof, but it's a promising signal. Well, we are doctors, and we know that when we want to treat a patient with severe MR, we should look at the tricuspid disease. No way to have a good long-term result if you treat a patient with severe mitral disease and neglect the tricuspid. So, what about the percutaneous tricuspid valve intervention? Very, very few things. Most are only videos or movies for kids. So, another very interesting approach is to consider transcatheter treatment after surgical failure. The first thing is mitral body prostheses are very attractive, but they fail, and even earlier than the aortic prosthesis. And there has been attempts to perform the mitral valve replacement transcatheter. Most cases were done transapical, few cases were done transeptally. Here is the valve in the valve. What is the total experience reported, published? Something less than 30 cases probably, very few series, most transapical, all sorts of bioprosthesis, but there is a problem of limitation of size. There could be failure. There were failure essentially in the early phase using the transvenous. There could be complication. Hemodynamics is not perfect but acceptable in terms of gradient, and leakage is good. One step further, valve in a ring. We know that ring annuloplasty in patients with congestive heart failure will have a high frequency of recurrence of MR. The first attempt was done by Dr. De Wegeer from Leiden transapically, and we did the first transeptally. And you see here the valve in the ring and how nicely it fits into the ring. What is the huge experience worldwide reported? This afternoon you can go and see a nice poster. 5 centers to show 15 patients, very, very sick patients. We cannot cover all size of rings, of course, transeptally or transapical. Procedural success was quite high. Gradient, well, it could be a concern. Good result on MR. We may have some gradient, intraventricular gradient, and with a very limited follow-up, promising functional result. It is just the beginning of the story. And we can imagine combining this procedure with other transcatheter procedure. Here is the transcatheter aortic valve plus a transcatheter mitral in a ring, and we can imagine further combination. But Dr. Nuti is there. I apologize for this poor slide, but you will fully agree we cannot imagine progressing in the field of percutaneous mitral valve repair without improving the imaging, and here is one solution where you have the CT arm, the angio arm, which follows the TE, etc., etc. So to conclude this too short talk, I would like to say that today, with what we have, the current result of edge-to-edge technique suggests that it may be helpful in selected high-risk patients. But we need long-term follow-up and randomized trial in secondary MR where there is a real clinical need. The results of coronary sinus annuloplasty are disappointing. Research is very active and ongoing. More than 20 devices are being studied. The evaluation of the new device should aim at reproducing surgical techniques. No way to be successful if you don't go this way, and combining the technique. It is mandatory for percutaneous mitral valve repair. Transcatheter valve replacement, very, very early days. It's an attractive option, but will be challenging. Preliminary data on transcatheter treatment after surgical failure are promising, but shows only today that it is feasible. And really the message to end with is a new mitral transcatheter technique may represent a satisfactory palliation in patients who are high risk for surgery or inoperable. But in my opinion, at least within the 5 and even 10 years, it's unlikely that they could be applied to lower risk patients. Because we should always remember this sentence from Catherine Otto, and remember that in primary MR, results are fantastic with surgery, so we need to be sure that with percutaneous technique we do not sacrifice proven long-term effectiveness for short-term issues such as convenience, invasiveness, or irreversible procedural complication. But, don't be pessimistic. Remember that Professor Carpentier needed 20 or 30 years to improve the technique of mitral annuloplasty. So the only thing we have to do is to work all together. Thank you for attention.
Thank you very much for this very encouraging up-tempo presentation. I think you did an excellent job. Just one question.
I have just one question.
Yes.
First, despite the fact that you had to shorten your presentation, Dr. Shahata from Egypt wanted to congratulate you for your great presentation.
Thank you, Dr. Shahata. May I communicate with Dr. Shahata to thank him?
Yeah. Okay, I will send him an email. One quick question. Would you select the patient for percutaneous mitral valve therapy? Who should select? Cardiologists, surgeons, clinical cardiologists, heart team, imaging?
So this question is very good. It was on one of my hidden slides, of course. Heart team. We should apply exactly the recipe which worked for TAVI, and that's the only way to go. Is it short enough? Okay, thank you.
Thank you so much, and thank you for this session, attending it. Thank you.